What is the flexor of the shoulder joint? We can add a external rotator. What is extensor of the shoulder joint? Subscapular is internal rotator. Functions of the rotator cuff is not alone by rotating the shoulder.
When it comes to shoulder, one of the biggest mistake is that we consider everyone will have the same structure. So for example, same size of a clavicle and same glenoid position.
I would imagine when I study, hip joint rotator cuff is acetabulum. Anatomically, if you see, none of the joint have this structural orientation, which is a muscle attaching as close as possible to the joint, which significantly influence the biomechanics of the shoulder joint.
When it comes to rotator cuff, people think always very important thing supraspinatus. That is a major thing which is initiating abductor. All those rotator cuff related special tests are outdated. It is not clinically recommended to be used in a practice.
Now you have an acetabulum
For shoulder.
for shoulder. Now you have acetabulum shoulder, but the problem here that is static. It is dynamic.
Impingement is a real thing. So if there is a space issue actually happening, then all the decompression surgeries should have been worked.
1952, who created the Neil's test to do shoulder surgery?
Whenever you are having shoulder pain or a neck pain like that, people used to assess scapula, how it is moving symmetrically.
Yeah.
Definitely in my life, I won't use my hands in a symmetrical pattern. Because usually we'll see what we are looking for.
Yes, that is excellent. Which means many factors are influencing
Can
this rhythm.
influence. This makes me question one thing. If scapular movement is not happening properly, then it might lead to impingement. Will that be a case?
Hi everyone, welcome to another podcast. In this podcast, we are going to discuss in detail about the shoulder joint and mainly anatomy and biomechanics in depth of the shoulder joint, because that's the most important component. It's not like another joint. Everything looks little different when it comes to a shoulder joint. If you understand the shoulder joint biomechanics anatomy very well, next part to assessment, diagnosis, and how to classify the shoulder pains, treatment, everything will get very easy and smooth. So further followed by, we're going to discuss about the how to diagnose the shoulder joint. This is episode 2 actually. If you missed to watch episode 1, we discuss elaborately about the low back pain, how to diagnose and treat and everything in detail as well. So you can check out that. I'll add it in icon here. You can have a look after this listening to the podcast. Definitely the podcast will go around 1 hour or plus 1.5 hours maybe. The motto of the podcast to convey information as much as possible. Not necessary how to sit completely and watch whole podcast in a single day. 30 minutes segregate and just watch as clear as possible. Don't try to take notes and all. Just listen. If anything new, go search, evolve and improve yourself. We are also constantly evolving. So we all 5 again AEP classroom members. So we are all taking classes regularly. Now we'll start with the anatomy and biomechanics of the shoulder joint. Okay. What are all the points we're going to cover in the anatomy and the biomechanics of the shoulder joint? We'll start talk about it.
Actually, when it comes to shoulder, one of the biggest mistake is that we consider everyone will have the same structure. So for example, same size of a clavicle and same glenoid position, same acromion process. So it's not same for everyone. There are a lot of variation in anatomically. So that's the process where we go wrong in assessment. So we just misdiagnose few things.
You say different type of acromion, everyone knows. Right?
Yeah.
Type 1, type 2, type 3. In similarly, different type of clavicle also there.
Yeah, there are.
The shape.
It's not same for everyone. Medially,
attachmental
laterally.
variation. Yeah. Glenoid sizes also vary.
Exactly, comma shaped, pear shaped. Likewise, there are different types.
Great.
And
Humeral head variations.
torsion wise, there are little variations. High torsion, low torsion will be there.
People who do in throwing activity, throwing sports, lower portion of the humerus is not aligned with the upper portion. Lower portion almost rotated posteriorly, which helps to go high amount of external rotation due to an adaptation in nature, spiral fracture. how it happens in the shaft of humerus. It feels like rotation in the adaptation. That is a natural adaptation to the athlete. Wrong. So what we are trying to say from this? That
Major learning is everyone will have different anatomical structures. So as soon as when they have pain, we should not blame the anatomical structures, and we can't expect every people should. There is something called normal range of motion, normal scapulohumeral rhythm, normal anatomical pattern, like that. We can't expect.
Exactly.
so it's applicable for whole body.
Whole body.
yeah,
Exactly.
But a lot of research evidence also, cadaveric studies also available for the shoulder joint to prove this individual variability is so common. So don't expect.
Even when it comes to anatomical structure, labrum for few people, there is absence of labrum is also a normal thing because and the shape of the triangular labrum is there, circular, rounded labrum is there. So variations are there. So once they got an injury and we suspect that that is the problem for their problem, means that's not really.
So structural variability is so common in mainly shoulder joint. Mainly shoulder. No? So that's one anatomical part of.
And shoulder itself is a complex structure, what I feel, having more of mobility and very less stability, and that is where we need a lot of stability for the joint.
Stability demand is so high in the shoulder joint compared to which structure is doing that, creating that work of improving the shoulder stability majorly.
Labrum in
Structures means labrum.
Every 5-mark question, Suraj already learned that static stability, dynamic stability. We're not going to talk about it. Definitely, labrum, depth of labrum, structural articulation, and other ligaments around that, superior, inferior, humeral ligament, coracoacromial ligament, every ligament, humeral, coracohumeral ligament, anterior bundle, posterior bundle, all things definitely going to provide stability. Capsule. We are not going to deny anything. Negative intra-articular pressure too, because having negative intra-articular pressure in every joint makes make congruence of the every joint to maintain in a good position, because it has to, if it is negative, outside atmospheric pressure is a little more, it is negative, then it has to reduce the volume to maintain the atmospheric pressure to internal joint pressure. So that is also, so many factors influence, but in detail we are going to talk about the rotator cuff. Majorly that four muscle. The four muscle.
So rotator cuff is also located in the hip also, but we are not majorly talked about and studied about that. So like all the piriformis and inferior gemellate in lower limb, and especially because the hips have the high anatomical structure stability, the high convex and concave, but
Continue.
but here we need more structural stability and stabilizers that is should given by the rotator cuff.
Rotator cuff. I would imagine when I study hip joint rotator cuff is acetabulum.
Yeah.
Yeah, there is as he said, superior gemelli, inferior gemelli, piriformis, so deep muscles also doing that job in a very good nature. But anatomically, if you see, none of the joint have this structural orientation, which is a muscle attaching as close as possible to the joint, which significantly influence the biomechanics of the shoulder joint. We will detail discuss about the concave convex rule, how changes in the shoulder joint compared to other joints. We will detail discuss about it. So
when it comes to rotator cuff, people think always very important thing supraspinatus. That is a major thing which is initiating abductor. Some many reels, YouTube reels and all, just they will do initial 15-degree abduction with a resistant to strengthen the supraspinatus. But actually, supraspinatus is not an initiating abductor. It is work as a full range abductor first of all.
Still it's in textbook. What we learned is 10 to 15
degree abductor is supraspinatus. But there is some research. It shows along with the supraspinatus, almost 7 muscles are working: deltoid, upper traps, lower traps, serratus anterior, infraspinatus, like that. Everything is working to initiate abduction. But it is not only initiate abductor, it is a full range abductor also.
I'll explain about the study. The study which is placed EMG for 7 muscles, which is trap, subscapularis, supra, infraspinatus, teres minor, teres major, deltoid. All 7 muscle replaced EMG electrode and asked healthy individuals to just raise the arm. They were trying to find out the fastness, speed of contraction. muscle firing and initiating the contraction timing, and they found out except subscapularis, all other 6 muscles are activating at the same time. So this theory comes from if you know the back pain. In back pain they will talk about transverse abdominis activation is very important. No, transverse alone doesn't activate. Supra doesn't alone activate. So one single muscle for a moment doesn't alone activate. Every muscle active together. So speed of contraction, initiation of the contraction, all other 6 muscle like as I said, deltoid, upper trapezius, everything is same. It doesn't mean supraspinatus alone initiate the shoulder abduction. That has to be unlearned. Unlearned. And supraspinatus is very good abductor, a full range through. Definitely, it is not strong as a deltoid. It is bigger. Deltoid is bigger. Deltoid has a priority. Definitely yes, but supra also do the same work.
And why it is initially emphasized that 0 to 15 degrees is being carried out by supraspinatus is because of its biomechanical advantage. The position, when the arm is at the side of in the neutral position, so supraspinatus will have the highest momentum and highest torque production. But it is a very small muscle compared to deltoid, so it cannot carry out the entire abduction. And obviously, deltoid is having mechanical disadvantage at that position, so it will go hand
That is when initiation of abduction theory comes, and we are believing and going behind it. But critical thinking plays always a crucial role. And also during a rehabilitation, you can't activate a single muscle. You can't give exercise to supraspinatus alone. You can't give exercise to subscapularis alone. Group of muscle, because you're going movement.
not the muscle.
Yeah, isolated movement also will activate couple of more muscles.
And that is also a reason why we usually study about agonists, antagonists, synergists, everything, not just agonist alone.
Perfect.
So for every movement, all the functional group of muscles has to work on to carry out the movement.
Exactly.
When we talk about this concept initiating abductor, I want to discuss about empty can and full can test. Usually what people think to analyze supraspinatus tear, empty can or full can we will assess, right?
Yeah.
But during abduction, all the 7 muscles, more than 7 muscles.
You're not going to test the supraspinatus alone.
We can't isolately check the supraspinatus. So the specificity, sensitivity for a full can and empty can test is too low. We can't isolate one structure.
From that you can assess abductor strength.
Yes. We can't assess supraspinatus.
And research has shown it, it has proven it. Like most of us would have known about Jeremy Lewis, who is the one who coined the rotator cuff related shoulder pain. So in a 2020 study, he and his colleagues have demonstrated that all those rotator cuff related special tests are outdated. So it is not clinically recommended to be used in a practice. And also it is 2020 study, most recent. But the actual history tracks back to 2008, another study, a systematic review. And in that systematic review, they have analyzed it and said most of the clinical tests are not relevant or reliable in analyzing an isolated structure. And that doesn't mean we cannot completely use it. We should not completely ignore it. You can use it, but as a cluster of tests, not a single special test. And again, as ma'am said, we cannot use it to analyze a single structure, single structural pathology. It will be a combination of all the structures involved in the movement.
Yes.
So it doesn't mean special test you should avoid.
Yes.
So because whenever we are talking something about the MRI, whenever we are talking something about special test, something like, it doesn't mean you should not do it. You should know when to do it. That is a more important quality. Even though the special test, as Kritika ma'am pointed out, sensitivity is very low. It's okay, but the clinical correlation, the history part that we are going to discuss in detail. But when to use, if you know, that could be a more better way to utilize a special test. Everything has a value. Everything has a value, but your critical thinking going to decide the value, not alone the test. Not alone the test, which I want to add, I felt.
I don't know whether I can add this right now. There is a Tamil saying, Kalavum Katrumara. So we have to learn everything to know when to not use it. So that is also a thing we'll have to analyze. And about MRI, I would like to add on one more research paper. It was in 2018, I guess. I'm not sure about the author. So in that study, they have analyzed 123 people.
123 individual MRI, understood. Painful and pain.
Non-painful shoulder. We usually, we usually say about interpersonal variations. Like not two persons will have same MRI and same clinical features. But what about having same amount of MRI image changes in the same person and different shoulders.
Exactly. People have a right side shoulder pain. Actually, the study what they did, they taken an MRI bilateral shoulder, but blinded an orthopedician and radiologist without informing them which shoulder is actually painful, and asked them to give a report. And it shows almost similar.
Similar.
Every structural problem is similar. Their labral tear is 67% in painful, 66%
Non-painful shoulder.
except full thickness. Full thickness, only a significant difference they found out in full thickness supraspinatus tear. Full thickness have a clinical significance. When the MRI finding shows 5% of the people have a full thickness rotator cuff tear in a painful side, but only 1% of the people have a non-painful side are diagnosed with the. When I say 1% of the people, even without pain, diagnosed in MRI full thickness rotator cuff tear, supraspinatus tear, which is also a normal variation. Many people will have a tear without pain. That is when the anatomical structure of the rotator cuff plays a beautiful role. We all know supra comes up. So simply, when I say acetabulum, see, very small head of humerus, very small glenoid cavity, which is surrounded by the glenoid labrum. Slightly it increases the depth, but still it is not enough to maintain the congregate, because the shoulder joint has to maintain in a place, central. If it goes front, back, up, down, that is called dislocation.
Dislocations.
It can lead to structural damage, ligamental structural damage, or bony structural damage, which is called Bankart, heel sac lesions, and ligament labral issues, slap lesion, and so many variations. It has to maintain central position. So to do the job, so acetabulum, this is acetabulum, this is a glenoid. This is acetabulum, which is covers.
Yeah, okay.
This is a glenoid.
Yeah, okay.
But to do that, supra comes and
Pocket and superiorly.
and subscapularis come anteriorly do the work. Infra comes posteriorly to do the work, and teres major and minor comes also in the same position to do the work by creating like a acetabular structure.
Okay.
By creating imagine
Yeah.
now you have an acetabulum
Yeah.
For shoulder.
for shoulder. Now you have acetabulum shoulder, but the problem here, that is static, it is dynamic. That is when understanding of biomechanics comes crucial role when it comes to shoulder joint. So now it covers like this. It covers the head of humerus like this. Now translation won't happen. So this is the beauty of it. Now many cadaveric study which is found that supra to infra, long head of biceps, and subscapular is all interconnected. This is all interconnected, and there is a crescent and cable structure. Like how it bridge it forms with cable with structural support, it will be like it will form. We'll try to add the pictures here for you to better understanding. So the cable will connect all four rotator cuff muscle. From there is sheath which is going to attach that crescent. That is called crescent in the glenoid. No. Humerus. In the humerus. That area, if you have a tear, you will be asymptomatic even without pain.
Because all the load bearing will be gone to the cable.
Cable structure.
Cable is the structure which just helps to distributing the force. So that is why people are asymptomatic. And after 50 maximum, if you are taking MRI, it shows rotator cuff.
Similarly, last podcast what we discussed, degenerative changes in a body cannot be reversed. It will be visibly seen through MRI. It doesn't mean that's the reason for your pain. Just understand your warranty period got over at the age of 30-35. So definitely you may end up having some pain in the future because low tolerance capacity is getting reduced. But in age of 25 also, if you do clean the fan for half an hour, same workload. In the age of 55 you do the work also, it has to be a same workload. But do you have a tolerance? That is what is going to determine. Do you have repeatability, adaptability to do the task? That is what is going to determine. Just understand that. And also importantly, just to add quickly, duration of the pain determines everything. We'll talk in detail about it when it comes to a pain podcast.
As you add, like in an MRI for a ligament like that we are seeing, we can't actually localize which structure is involved for that pain.
Exactly.
It can either it can be bursa, either it can be ligament or any tendon. Anything can cause the pain there. Not only a particular structure what is shown in the MRI is the reason for the pain.
Reason for the pain. Always pain is multi-factor.
Yeah.
Also, just now, sir said everything is interconnected.
Yeah,
We cannot isolate it. Shoulder is actually too much crowded. In a small space, we have lot of things compressed into a space. So we cannot isolate it, and most of those are interconnected.
Exactly.
And actually, I thought of bursa as something in between a muscle we have one small structure. That's called bursa. I thought like that. But bursa is something,
Bursa is
it's a very large structure which is going to cover a lot of parts.
In the shoulder. Actually, in cadaveric study, bursa looks like a deltoid.
Oh, that big it is. Not that small.
And some
It covers the entire glenoid.
maximum it's a very big in size, so and it is highly rich in nociceptors, high blood supply, nerve supply, and nociceptors. So small inflammation, any trigger is stress itself, it can the nociceptors can trigger.
Yeah.
So we can't localize which structure is affected because it is very big. It is cover almost the entire thing. So supraspinatus is affected, labrum is affected, biceps is affected. We can't localize because in the presence
That is why
of
some
bursa.
patient face some difficulty to locate the pain. I have they will diffuse kind of pain in some shoulder case due to bursa maybe, and because bursa is not as small as we have seen in the anatomy textbook.
Exactly.
Actually bigger than what?
And even some textbooks are saying it is named not only as subacromial bursa but also subdeltoid.
Subdeltoid bursa.
Subacromial and
Exactly.
subdeltoid bursa. So it is in,
It's covered the whole structure.
Under the deltoid.
also.
Bursa also not have a significant same size to measure. It also very depends on individual to individual. And many couple of studies, cadaveric studies have shown that 35% of the individual doesn't have medial glenohumeral ligament.
Yes.
And ligament to ligament structural variation also very common in individual according to their developmental adaptation. So when it comes to this, I would like to explain why this much variations was there. Why this much variation? We have explained many times in certain reels. What is anatomy? We have to understand first thing. What is anatomy? We have to understand. The greater tubercle which you are seeing, which is not there when you born.
It's because of the pull what you do.
Exactly. The size of a greater tubercle is differ. How you moved your body, but naturally from the birth to when we get older, we move in a 90% plus we move in a similar pattern. That is why structures are looking little similar to each other. But when you take the cadaver one bone to another bone, small difference is always there. A lot of cadaveric study has been proven. Your tubercle size and my tubercle size is even not in the same length. Your supraspinatus size thickness and my supraspinatus size thickness is also not in the same length. So it will definitely impact.
And we can make an average or most common kind of anatomical structure, but we cannot standardize this is the perfect structure.
Exactly.
Maybe that could be the reason why if a person is practicing for a swimming means when the kid practices in 10 years means their structural changes will take place by the age of 10 itself.
Exactly.
So they'll show
If you take an MRI at the age of 18 or 20 for them,
For them.
slap tear,
Yeah.
spinous tear, everything. But that is normal for them. Without symptom, that is normal.
because the structure has got adapted to that sport.
Normal adaptation for that.
For example, javelin throwers or the cricketer, anyone would have adapted those structures.
Exactly. When you get pain, it is suddenly if you go for procedures investigation, this is not the reason, as we always say. So clinical correlation is always there.
And coming back to bursa again, so just like how we tell tendon is adaptable, how the labrum, everything is adapting to whatever the load we are placing, bursa is a lively structure. It will also adapt. So what the thing we see as bursa thickening in the MRI might not be actually pathological. It might be a adaptive change.
So we are all talking about rotator cuff. So major role of rotator cuff is acting as a dynamic stabilizer. So just we all have to know how it is stabilizing the shoulder. So whenever we are moving our shoulder in a flexion manner during pushing exercise or any in a pushing moment or flexion aspect, roll and glide has to happen in a posterior direction. Yes, it has to go back. But when we go for flexion, anterior muscles has to work. Flexor has to work. So this flexor will contract. So our humerus will translate anteriorly.
By pulling off
Flexors. So during flexion, by the pull of flexors, humerus will go. It will translate anteriorly because Passively, we are not having acetabulum in our shoulder, so it can't prevent translation. The congruence is little less, so we are having fully dynamic soft tissues for that. So anterior translation will occur. To prevent this anterior translation, posterior rotator cuff are working. It is contract and it will maintain the humerus in a neutral position. So this is how rotator cuff is placing a stabilizing role. Same thing during extension movement, during pulling movement, same thing happens. Because of the posterior side muscles contracting, our humerus will go posterior. It will translate posteriorly. But if it is posteriorly, means it leads to dislocation, subluxation. So anterior bony structures, slap tear will happen. So anteriorly prescended muscle, which is subscapularis. So that will contract and it will maintain the humerus in a neutral position. So in the neutral position, rolling and gliding will happen. So this is how rotator cuff is placing a stabilizing role. But it doesn't mean whenever we are moving, initially rotator cuff will stabilize, then movement happens. It is not like that. Along with other group of muscle, rotator cuff is also working and it is providing stability.
Yes, just to sum up, when you flex, your humeral head will pull anteriorly by flexors. When you extend, your humeral head pull posteriorly by extensors. It is a normal thing. It is a normal thing. But in shoulder, we don't have acetabulum, as ma'am exactly mentioned. So if it is happened, that is called Bankart relation, anti-dislocation. Translation is always lead to damage to structures. Translation should not happen because, as we all know, 4 times head is bigger than the glenoid. So small space has to hold. A slight movement can create a damage in the structure, leads to pain. That is when we are reading. So rotator cuff, how it's work out, let's explain. So when you flex, posterior rotator cuff has to equally, how much, for example, you are pushing 15 kg chair, something like similar 15 kg force as produced from the flexors to pull anteriorly. Similar 15 kg force has to produce by the external rotator to equally maintain the centralizing the head. So if you ask someone, if you ask to you what is the flexor of the shoulder joint, you can add a external rotator. What is extensor of the shoulder joint? Subscapularis, internal rotator, which is equally working to centralize the head. Rotator cuff, that is when the rotator cuff plays a crucial role. One of the important understanding you should develop during this podcast. Mainly, just go back and refer as well.
It will be very helpful in clinical practice when you are treating many cases.
When we talk about weekend pain.
Yeah. When you're understanding this concept, you can easily treat any kind of
activity based, like whether the pain is arising in the push activity or the pull activity, like we can
based on that we can
And one more beautiful point we have to learn from this: no need to activate external rotator, only with the external rotation movement. With a band like that, they'll activate.
Even by doing flexion activity, push activity
pushing,
also, we are going to activate the external rotator.
A lot of people complains pushing causes pain. Then absolutely external rotator can be a culprit of unable to maintain the stability over it. Pulling causing pain, subscapularis. So when it comes to elevation of the shoulder joint, when it comes to elevation of the shoulder joint, just imagine now inferior dislocation or translation, something should not happen. Now all rotator cuff has to pull the head towards the glenoid to maintain the congruence of the shoulder stability. So what is elevators of the shoulder joint? It's not deltoid. We can say rotator cuff. So functions of the rotator cuff, as Kritika mentioned, functions of the rotator cuff is not alone by rotating the shoulder. Functions of the rotator cuff also present in the flexion, extension, elevation, abduction of the shoulder joint as well, all the movement. So if someone asks what is abductor, all the rotator cuff.
Maybe that's why it got its name. Cuff is supposed to compress, right? So it is compressing the humeral head against the glenoid always.
If you understand what we talk this now, if you didn't understand, please put some effort to understand. Otherwise, you will not understand entire shoulder dynamicity and weekend pain, what we are going to talk in further. So, one study, even they analyze 25%, 50% and 70% of the one arm load with a healthy individual, ask them to do horizontal push exercise and ask them to do horizontal pull exercise, ask them to do abduction, lateral raise exercise. And the EMG electrodes are placed to analyze which rotator cuff activating when. The study revealed that all horizontal push movements, external rotator like infra is more active. More active. pull exercise, all the pull exercises when you perform, which is subscapularis, especially lower subscapularis is more active, upper also, and dividing the muscle fiber. So subscapularis is more active during extension activity, extension exercises. When it comes to lateral raise, all the rotator cuff activating at the same time equally. More active muscle is supra. More active in supra, then infra, then subscapularis. So please understand this. It's very, very, very important concept. If you understand this, you will understand next thing what we are going to talk.
If you're understanding this thing, you can easily understand why the supraspinatus is getting not compressed over 90 degree of elevation.
So actually there is a thing like when we ever do elevation, the impingement will
Be there, yes.
So now let's break the impingement theory. Then we can come to a concave convex rule. Why it's not applicable to the shoulder joint exactly? Yeah.
The concept is the space between the acromion and the glenoid is reduced. Okay, so when you are moving, you are elevating the shoulder. So now, if you're understanding the shoulder, the cuff muscles, how they are working in elevation. So already we mentioned the supraspinatus is working towards the glenoid cavity.
Yeah, pulling.
So pulling. So that towards the glenoid cavity. So the scapular also is going to move. The acromion process also is going to move, and the shoulder is also moving. It's not having any space reduction. Even though they have a space reduction, they're not having the chances of getting impingement.
Yeah, meanwhile, supraspinatus muscle get into the space already. There is no room to get an compressed. So actually, imagine we'll try to put some animation because the shoulder is very difficult to understand in podcast. So what ma'am is actually explaining, this is a humerus. This is where supraspinatus is attaching like this, and acromion is above here presented. Okay, when you are elevating, your shoulder alone is not elevating and impinging here. Everything moves together. Supraspinatus actually goes back. There is no room for impinging or compress the supraspinatus over the acromion actually. Another important point of explanation which we have to add, if the external rotator contract, it pulls the head anteriorly or posteriorly. Common. So to make the audience to understand, I'm coming to this way. It will pull posteriorly. Yes. The external rotator contract, head will move posteriorly.
Yes.
Absolutely, it will move posteriorly. Internal rotator you activate, it will move. Head will move anteriorly.
Yeah.
For sure, it will move anteriorly. When supraspinatus pulls, it creates the superior translation. So that is when a belief system is developed to everyone. So superior translation of the head of humerus is happening. So that is when impingement is occurring. But it doesn't work in that way.
Because of the deltoid, because supraspinatus is attaching very closer to the shoulder joint in the greater tubercle. So when it is pulling, it will obviously pull the humerus head upward. But deltoid on the other hand is attaching away from the joint, little away from the joint. So when it is pulling, it will not directly cause upward translation, but a downward translation. So consider my supraspinatus is attaching in the knuckles and deltoid is attaching in the wrist. So when this is pulling, it will move this way. But if this is pulling, it will not move this way, but in...
Exactly. So deltoid attaching here, if it is supra attaching here, when supra pulls up, but deltoid is stronger than that. If it is pull, it will go down, not up. But it will go down. It is not
because
up.
of the fiber
And
orientation.
also the inferior, the transition is not prevented by any muscles or something. So that is also
Inferior transition is not prevented by any
muscles because
But there is no muscles in inferior.
yes, inferiorly.
Capsule, bigger capsular
Yes.
pouch only presented. Because of strong congruity in superiorly, there is no room for inferior dislocation to happen.
And one more thing, when it comes to impingement, I ought to explain. After few degrees of abduction, our scapula is going to upwardly rotate. So when scapula moving upward rotation, our acromion also going up. So and humerus also going like this. So it is not, the space is not getting reduced, right? Because acromion is going upward. So
we should not isolate the shoulder to only humerus and glenoid.
So
we have to think of scapular also.
Sometimes in the lack of upper traps, lower traps activation also, we can feel some pain during abduction. It is not only by, we are thinking impingement is happen not only by supraspinatus muscle. If everything muscles are not working properly, it may lead to some pain.
So this makes me question one thing. So if scapular movement is not happening properly, then it might lead to impingement. Will that be a case?
No.
Like scapula is not moving upward properly, na? Then only humerus is moving like this. So it might hit the acromion, right?
We can't say it is getting impinged. It is slightly, it's got stress, that's it.
The muscle, there is a chance of getting stressed, but that time contribution of another muscle. See, now we have to create the probability why scapula won't move. Why scapula won't move? There is less chance scapular won't move. Even when you ask this question, scapular won't move, definitely there is a possibility for a hitting. Okay, because even many studies are 50% of the normal shoulder, when you elevate the arm, it is going to impinge. So we are creating the theories which what we learn from biomechanics and anatomy to made audience to think in this perspective. Now let's come into the scapula, why won't move. Even a surgical, post-surgical stiffness state, shoulder is going to elevate only 60 degree. In that 60 degree, how much scapula has to contribute, it will contribute. Right, scapula isolatedly won't move means scapular, suprascapular now some is severe nerve problem, muscular weakness in the scapula won't support.
And again, scapular movement is not isolated to one single muscle alone. A lot of muscles contributing.
So, for an example, supraspinatus is for the example, serratus anterior are not efficiently working due to winging of scapula. They will get a trapezius pain more. We used to have one person come with the complaints of they have a tumor in the upper trapezius. They removed the tumor in the upper trapezius, and he has a wasting of upper trapezius, infraspinatus. All scapular muscle has been wasted because of 6 months of immobilization. They didn't allow to move. Some improper guidance which has happened. He came with a lot of pain in the shoulder, deltoid region. If you have seen patients with suffering from stiff shoulder, frozen shoulder, they will mainly complain pain in this deltoid. So this will distribute the overworking, underworking of the muscles maybe, even though it is impinged, not the sole region at the time. Definitely biomechanical understanding helps to understand biomechanical concept of subacromial space will not going to hit. The similar biomechanics is going to not play the role actually what has to play. Then the dynamicity of that biomechanics, the acromial space also will not work efficiently. Right, so it definitely going to create, but the situation, when, how, it will going to determine. All the scapular muscle not going to insufficiently work at the same time. So if you hold someone's scapula from the axillary region to upper trap region and asking them someone to abduct, they can't elevate from beyond this.
Not even
they will stuck somewhere here. So which is, if you are going against biomechanics, definitely wrong thing happen. But what we believed before, normally impingement is happening. No, biomechanical alteration leads to an impingement maybe. That is when impingement, which is renamed into subacromial pain syndrome or rotator cuff shoulder pain. Then the rotator cuff shoulder pain also has to happen, right? Subacromial pain syndrome also has to happen. In 2016, it has been revised. Should not call in terms of subacromial impingement. If you say impingement, because impingement is not happening normally. Normal mechanics is working together, the impingement is not occurring at the time. So when the impingement is not occurring, if the shoulder pain, if you take the person, due to impingement, it creates a nocebo effect. It creates a nocebo effect in their mind. They will feel, I should not lift my arm. It is getting compressed or impinged over somewhere. So what is the meaning of impingement? We don't know.
It has been wrongly taught.
Exactly. So that is when that impingement word has been replaced as rotator cuff shoulder pain, as subacromial pain syndrome.
And if impingement is a real thing, so if there is a space issue actually happening, then all the decompression surgeries should have been worked.
Exactly. Though that is a beautiful point of discussion. So NEERS in 1952, who created the NEERS test to find if you are elevating the arm, if you are getting pain, you have shoulder impingement. To do shoulder surgery. Since then 2004, it has been improved, acromioplasty of shoulder, because they believed that subacromial space has to be increased to reduce the pain. So they remove the acromion. they remove the acromion. Acromioplasty surgery has been increased up to 750%. After 2004, the data. Why this many surgeries in the shoulder? Lot of systematic review, long-term follow-up, 5-year study. Again, 5 to 10 papers has been come out, meta-analytical papers. So many come out, and they prove people who go for subacromial impingement, placebo surgery, and non-surgical treatment improve similarly. No difference between the groups. Not one study which I am talking, multiple studies which has been explained. And also one systematic review, they were trying to analyze, understand the ultrasound with ultrasound and everything. Healthy individual versus painful individual. Is it difference? Can you find out any difference between subacromial space? No, there is no significant difference. Even you have pain, not having pain, your subacromial space. Painful person, pain is happening due to reducing the subacromial space. No, for you and pain-free populations, the subacromial space is same. Subacromial distance is changing over the period of elevation with the painful and non-painful population. No, there is no difference. It was same. So that is when update with the research is a significant create a significant impact on our clinical practice. Create our clinical practice. So
the
now
entire space issue is totally a scam.
scam. Subacromial space, subacromial distance is reducing. That's why you're getting shoulder pain. That is what calling impingement. No, it's completely wrong according to a normal biomechanics. If the biomechanical alteration was there, it can relate it to shoulder pain. But don't call that as a subacromial impingement. Yes, the pain has to come for the shoulder. How it will come? My muscles is not working efficiently. The biomechanics, again something has to happen, pain will come. So as I mentioned, people have a PA shoulder. That case which have upper trapezius wasting, they have pain here. And I will put the image of that case. You can see significant hypertrophy in this deltoid compared to non-pain facet. I'll put the image also here. So similarly, if you notice people who have a rotator cuff functional issue, not efficiently working, they were trapping. So exactly. So body doesn't know who is working, who doesn't working. Body will, brain will try to trigger. So he is going to elevate them. Supra, are you working? Deltoid, are you working? Please people work. No, will not work. If that signal is not efficiently reaching, definitely what is the next? Muscle is contribute. Body will try to complete the task. Somehow that is when most of the individual will have a pain in the upper trap. Mostly. So we'll also talk about the distribution of the pain and how it plays significant role. Before, what do you people think about the upper trap pain when it comes to shoulder joint? How to handle this?
So the thing that upper trap is being blamed and sabotaged for no reason is actually a thing to be noticed here. So upper trap is not alone the one which is causing scapular movements or something. We'll have lower trap, serratus anterior also helping, but very much underrated. Those are very much underrated, and upper trap is being overemphasized, and it is very obviously seen. So more.
A muscle can get pain when it's do lot of work also, it will get pain.
Yeah,
and if you don't do much, give much deconditioning also is going to cause pain.
Going to cause pain.
Load
See,
intolerance.
consider someone have a upper trapezius pain. For example, he came to consult you 3 days back. I have upper trapezius pain. He did some work or he slept somewhere, something which has happened. Yes, upper trapezius pain. How do you manage? Because traditionally it is managed, Hema. Traditionally it is managed by releasing the trigger point, finding the trigger point, stretching. But honestly, even the therapist knows, the patient knows, that is going to get the significant short-term improvement. And again they are going to get that. Again they are going to release that. Again going to stretch that. Okay. So we are going to discuss in weak and painful shoulder, absolute deficit in the rotator cuff efficiency to produce the force and maintain the shoulder. So your another muscle is contributing that work, doing that work. That is when your upper trap is loading, because one of the important muscle for elevation. Because orientation is upward, movement is upward, upper trap is upward, so it is going to create that movement. So more than a lower trap serratus, it is going to work. Serratus also can work, I'm not denying the fact. Upper trap holding part is more isometrically compared when it comes to elevation. That is when upper trapezius is loading more. When you palpate, you are finding a trigger point. Okay, so how do you manage better If you give a guidance to audience, tomorrow don't need to release, don't stretch, how to manage?
In my perspective, so mostly the patients who have a complaint of upper trap pain, they will complain about I have more tightness over there. So whenever I'm doing something, I have more tightness and also I can't move my head. So sometimes as a therapist, what we think, okay, we are going to release it. Why? Because the range is restricted, because it's too tight. We are going to release it, or else we are going to stretch it. So some knot is there. So we are going to release it. Somehow we want to lengthen the muscle. That is the aim for every therapist. But that is not true. If you understand the concept of why some muscles are not working, why some muscles are working, means overactivated. So if you know the concept very clearly, that time we are going to strengthen the muscle.
Super.
We are not going to what the person says, okay, that is tightness, okay, we are going to release it. We are not into the person's, which means patient's words.
Exactly.
You have to think what is exactly happening.
So tight muscles also a weak muscle. So see, your rotator cuff is not working efficiently, your trapezius is getting loaded so much, it is getting pain, which means your trapezius also exceed the capacity to load. Either strengthen the trapezius or either strengthen the rotator cuff. Either give some push pull movement, improve the ability to tolerate the load when it comes to shoulder, or activity modification which helps. But I have to ride the bike for every day 1 hour, whatever happen. I have to sit and work, whatever happen. That time I'm getting improve the tolerance by doing activation, strengthening. Do one push exercise, pull exercise, activation, rotator cuff exercise, or trapezius strengthening exercise.
Maybe in simple words, don't do what the patient is asking you, like stretch me or give some release. Do what the body is asking. The upper trap might be craving for some strengthening.
Yes,
exactly.
So that is what we have to give it.
Absolutely. So don't try to release and don't try to stretch alone. So you have seen it is not going to help. So please try to activate the rotator cuff. Try to activate the trapezius. Definitely patients feels better.
Because of any movement only, or doing any activity only, the pain has arrived, means your treatment should also be in active way. So
This helps a lot better. But it doesn't mean you should not release stretch. You do that, but at the end, if you want a permanent cure, go for the strength training
yes,
of this muscle to better tolerance of the load and find the weakness where it is and work accordingly. So I think we covered many things. So now we can move into scapular structure, which is rhythm, dyskinesia, biomechanical aspect. So almost 17 plus muscle attached to the scapula. So what do you people think about scapulohumeral rhythm? What textbook says that is 2:1 or 3:1 ratio?
2:1.
2:1 ratio. Not necessary to know that. So
It is actually made by one cadaveric study, 1944, one cadaveric study. So we can't rely on that scapulohumeral rhythm. Sometimes we discuss, right, rotator cuff having some weakness means as upper traps or lower trapezius will take load. So trapezius can cause some movements in the scapula. So it is very common. Sometimes people have 3:1, 5:4, 1:2, like that. It's
different study has been shown that as well.
and sometimes, usually whenever you are having shoulder pain or neck pain like that, people used to assess scapula, how it is moving symmetrically. Definitely in my life, I won't use my hands in a symmetrical pattern. Right side, how much using? Like the same way, I can't use left side. So we can't expect symmetry in the scapula also.
so which means many factors are influencing
Can
this
influence.
rhythm.
So what are all the factors influence the scapulohumeral rhythm?
Gender can influence the rhythm.
Gender
usually
means male, female.
Taking gender, the male have more upward rotation. So because of the broad shoulder, something, and also the female have more protraction. Breast. That is also reason. That could be the reason. And one more, now as sir mentioned, when the dominant hand and non-dominant hand,
Dominance of the hand
plays a major role.
And also when you're using both the hands, the rhythm will be different. When you're using
Single
unilateral,
hand, age is also influenced. 60-year-old men versus 16-year-old boys.
The rhythm will be different.
Scapulohumeral rhythm will differ because of the age factor, deconditioning, and degenerative factor, and so many things, and how much load.
That is also plays a major role, and how you are the speed of the movement also plays.
so when you're doing fastly, it's
Scapulohumeral rhythm will be different. You're lifting this whole chair, it will be different. So depends on the task, variability of the movement. It will movement experience,
And
movement
speed of the
experience.
moment, as they say.
Speed of the movement.
Sometimes fatigue.
Yeah, when the
Extremely
persons are
fatigue.
At that
Soreness
time-
means that time is scapulohumeral rhythm might changed.
Why? Because that time I'm activating other muscles to do that scapulohumeral rhythm. Which muscles fatigue? So reasons are.
Adaptability to the work they are involved in, like a sport population or a person who is into overhead movements a lot more occupationally, they might have a different
Scapulohumeral rhythm. So it is not similar as 2:1 ratio for every individual. As we started the podcast in the discussion of anatomical variation, so scapulohumeral rhythm also one of the important component into it. Someone maybe have a 4:1.5 ratio. Someone have a 5:3 ratio. Absolutely differ from people to people. Absolutely differ from people to
But
people.
But if you are saying that is not, we can't say that is normal also. When we want to say that is abnormal also, we have to know. So that is usually people think I want to assess the scapulohumeral. That is called scapular dyskinesia. Based on the scapular movement abnormality, they chooses that word and they call it as a one condition.
What
they
is
want
mean
to
by
try to correct it.
dyskinesia?
Dyskinesia means the
abnormal
one.
movement
Yeah.
of the scapula.
Yeah. So now we are ready to say there is no normal movement. Then why we want to know about the abnormal movement?
There is nothing called normal movement, so we can't find it which is
Which is
abnormal,
abnormal here.
first of all.
Yes.
Super. Podcast over. Actually, that's true.
Yeah.
That's true. I mean, today one patient, when I was coming to the clinic, he asked, "Sir, can you check, because he did shoulder surgery? Can you check my scapula?" Because Ritik was treating him, and he already checked, and he also worried that one side scapula moving differently, another side scapula moving differently. The social media bias, wording bias. These are all the things ringing of scapula. So no, I would say an example. Think about the person who doesn't have a hand. Think about the person who doesn't have a hand. They're also functioning well. They're not thinking about scapular dyskinesia. Their adaptability is different. Human body is helpful to complete the task. Are you doing the task comfortably? Are your rehab is going well? Are your pain tolerance is getting better? Are your load tolerance is getting better? Are you getting confident? Let's look at that. Yes, surgical side, scapula will definitely move different than a non-surgical side, of course. If you overthink about it, if the person doesn't have a hand, has to think more than you, but they are surviving good. So I educated him in a certain way that it is normal, and I took a video of him. I will try to post the video as well, and I took a video of him and put it in a slow motion and explain, see, both are moving similarly. Both are literally moving similarly.
Because the thing is, in scapular dyskinesia, the assessment bias are there. Because when I take a 10 therapist on two
Yeah, I know that study. So 14 observational study is there. So 2 physios, that is one is blinded, one is non-blinded. So 135 the population, that is bigger. So they are going to assess the scapular movements. So in that they both were into 63 and 65 somewhat.
Painful population and non-painful shoulder.
Painful population. So in that they couldn't find out which one is painful and which one is non-painful.
Therapist was blinded, who doesn't know which person have a shoulder pain, which person doesn't have shoulder pain. They couldn't able to differentiate the scapular dyskinesia in the painful and pain-free population.
Yeah, so that time there is no need of there is a scapular dyskinesia there or not. Yeah.
Because usually we'll see what we are looking for.
Yes, that is excellent.
So actually the thing is, when I want to see that, okay, one side deltoid is bulkier than the other side means, I'll say, okay, right side is bulkier. Likewise, I will think and see it. So that's what Malti is trying to tell.
like,
What I want to see only, I will see in that.
Exactly. So a patient coming with the complaints of right shoulder pain, when you are trying to assess a scapular dyskinesia, it looks like right side is moving little abnormal. Because as Malati mentioned, it's really what you want to see, it will be.
Many times I asked this question to you. You assess flexion of the shoulder, but what you assessed, I don't know. You say to the patient like, yeah, little deviation is there, but
No, sometimes will not use purposefully because patient belief system is so strongly influenced. Within one single consultation, we can't change their mindset. Okay, they were expecting for reason for pain, and will without harmful manner rule outing all serious pathology. politely, okay, this may be the reason to satisfy themselves. Exactly. To satisfy themselves, slightly something can be used that we can detail discuss about the assessment part, another podcast. But here the patient is going to the treatment. Once the pain get reduced, will explain and make them understand educate during the process. If you say
go with their flow and then
exactly, as in discussed in last part, if you say everything is normal, you're looking good, then why you have to come there last? Because as common man doesn't know, they got pain, they have some reason should be there.
And the therapists, they need to aware when we called as a scapular dyskinesia, the vomiting sign.
Good.
That's my next question.
Just correct, continue please.
So the suprascapular nerve, some long thoracic nerve, the major muscle that is supplied by the nerve itself compressed or damaged means obviously the muscle is going to wastage, not weak itself. So wastage. The muscle bulk itself is reduced.
At that
I
time,
think
the movement will not be
when
efficient.
we can say we have scapular dyskinesia, we have to look for vomiting signs. Very awkward, abnormal pattern.
So when someone is you're assessing scapular movements, you have to feel. So too much. Somehow you feel awkward. Yeah, this is absolutely moving something differently compared to one side. That can mostly happen to nerve related problem. If the non-nerve related problem which has happened, that's adaptation.
If you are suspecting something different, please refer to the nerve conduction study or something. So you want to rule out the nerve related
Very least probably.
Yeah.
Least probably when it comes to shoulder pain leads to scapular. That is also caused by, as Malati was asked the question, scapular biomechanics is going to change that influence the shoulder. Then that theory works. So normal biomechanics is going to reverse, not working in a normal way, so that cuff pain, rotator cuff pain, subacromial pain syndrome can happen. So that's good. Basically, look for awkward sign when you assess. When to assess? So if you are already looking for awkward sign, patient come with the complaints only. They will only know my scapula is moving differently. But someone is saying my scapula is moving differently, you should assess. But if feels a slight difference, that doesn't going to make any change, because for all 5 of us, if we do a squat, all 5 is going to do different way. So all 5 of us lift the arm, all 5 scapular move different way. One side is maybe used more, one side may be used less, one side adaptability is different, another side adaptability is different. So no single study which is demonstrated that there is a relationship between scapular dyskinesia and your shoulder pain. When I say normal individual, non-neural affect population, because many overhead athletes, swimmers normally have a scapular dyskinesia. When they assess the shoulder, normally they have a scapular dyskinesia because the muscles are altered, bones are working, and the scapulohumeral rhythms are altered regarding that way of the individual who want to efficiently perform certain task in a competitive nature or something.
So for scapular dyskinesia to be noted and to be addressed, it should be very obviously misaligned, and everyone seeing it should feel it like it is not okay. So that might
So not necessary to assess the scapular dyskinesia for every patient until there is a requirement. That is when yes, scapular dyskinesia assessment is important, but whom to assess is going to increase the validity of the scapular dyskinesia assessment. All patients with the complaint of shoulder pain, you are going to assess all scapular dyskinesia for everyone. Is reduce the validity and reliability of the scapular. It feels that you are narrow-minded. You are trying to find the dysfunctions. Trying to find the dysfunction to the person to say this was the reason for your pain. So again, we have to understand the multi-factor nature of the pain and why shoulder pain is coming. We have to discuss in diagnostical part anyway. So anything which we miss to add when it comes to shoulder anatomy, biomechanics?
not regarding the shoulder alone, but regarding all the things we are looking for, or when a patient is saying, my one side is moving differently, why might that be? Even if we are saying that it is normal, they might not be able to understand it. But the diagnostic term for that is you are a human. So I came across this in a social media post. I don't remember where it is, but being a human, skeptical physio. So being a human itself is a diagnosis. No one is perfect here. Being imperfect is also nice, right?
So I think we covered many things when it comes to shoulder anatomy and biomechanics. Scapular dyskinesia, trap and rhythm, functions of the rotator cuff, many things we covered. Anyone want any more point before moving to the part 2 of this episode?
I would like to add on a point in the cable and crescent model we were discussing, that we discussed that when there is a tear happening in the crescent, cable will be there to support. So there might not be a obvious symptom. Even though tear is there, symptom might not be there. But what if tear happens to the cable structure itself? Because that is the weight bearing that is responsible for
So
distributing
the cable
load.
means connecting section of all the rotator cuff
Rotator
in near to the shoulder, the head of humerus attachment.
That superior labrum
Yep,
where
yep,
it
yep,
is
yep,
present.
yep,
So when there is any tear to that cable structure, that is one which is supporting the entire rotator cuff, so it might be symptomatic. So that is why some people with rotator cuff tear is having symptoms and some might not have. It doesn't only mean about the full thickness or partial thickness there, but also about the location.
Either
Not
it's
only
crescent
the
or the cable,
cable.
it's getting affected.
So-
That's why many people with in MRI where they diagnosed with any tear or something, but they will not have the symptom itself. So because of this cable is preserved crescent is only.
Perfect. So another thing which you have to understand, most importantly, strength of the shoulder. Strength of the shoulder, extension, abduction. Sorry, adduction is more powerful. Adduction, and then you can put extension into place, and then you can put to flexion into place, and then you put to abduction into place, and then you can put to internal rotation, lastly external rotation. So this is the order. So if you are testing the adductor muscles strength, you have to give more resistance to that. You are testing external rotator strength, you have to give less resistance to that. Because of the thickness and amount of muscle fiber, also one of the important point to understand the strength of the each movement. So adduction is first, external rotation is last. So that order may be helpful for you to, when you test how much force I can give to which structure, it will be helpful, which I missed to add. So
and that might also be clinically
very important when it comes to anatomical nature of the shoulder.
Same joint, but for different movement, different kind of force should be delivered.
Exactly. So hopefully we covered everything about anatomy and biomechanics of the shoulder joint. I know it's very deep and depth. Sometimes you may not understand everything. It's okay to pass and go back and find the research paper. We'll try to add all the research paper here. We'll put it down in the description. And also I'll try to edit this video. While editing, we'll try to add more animations and things to make you understand things. Actually, we came here to discuss, make this one podcast, but when discussing about anatomy and biomechanics itself, it took almost an hour. So we're planning to release this shoulder podcast as 2 episodes. This is the first episode. You're going to see only anatomy biomechanics. In second episode, wait for the next episode, which is going to out released in next 1 week, which we are going to discuss about how to diagnose shoulder joint and treatment for the shoulder joint. That is definitely, as I give an intro in that part, it's going to be very simple and 2 good information you're going to learn about the part 2, which is going to discuss about diagnosing of shoulder joint. So until, thank you. If you have any doubts, discussion, put it in the comment section. Let's have a conversation, more detail in the comment section. Thank you and happy learning.